So hello, I'm going to talk a little bit about facelifting today. And you know, there's a lot of videos I've seen, maybe you've seen some too, out on the internet, describing how facelifts are done. And I wanted to emphasize, I find a lot of those videos are pretty good, but sometimes they're a little bit convoluted and confusing. I'm going to make my effort to explain one key concept to do with facelifting that I think might be the most important concept that you should be thinking about, perhaps when you talk to your surgeon about an upcoming surgery that maybe you're considering doing. So in order to help us with this, I put together this very schematic, stylized sort of model of the human face. So to give you some orientation here, this is 3 layers of tissue. Sort of the tan layer here is supposed to represent the facial skin. And then if you peel that back a bit, we've got this red layer, and the red is supposed to imply muscle. So this is sort of the muscular layer of the face. Sometimes surgeons refer to it as the SMAS up here in the cheek, but then the platysma muscle down here in the neck. And then if you peel that back, this yellow layer is supposed to represent a thin fascial layer, and under that is the facial nerve, so that's no-go territory. That's where you need to stay out of if you're a facelift surgeon. Additionally, we have these, what about these pins? What's that supposed to be? There are these fibrous condensations, these fibrous anchor points that are really tough in the face, and they're a main part of this story. This is part of the main idea that I'm getting to. So there's several of them. There's a zygomatic anchor point, masseteric, cervical, meaning in the neck, and this is mandibular right here. This is where the jowl forms around. Okay, and then finally, last point on this diagram, to give you some orientation, think of the face like if you're looking at it from this side, the neck is down here at the bottom. This is the ear. So as you know, with a facelift, you've been making an incision in front of the ear. So this is where the incisions will go when we talk in a second. This is the nose, so opposite the ear, here and here. And so this is the front, this is the back, this is the bottom, and here's the eyeball up here, sort of on the top of the cheek. Okay, so to start the story, how are facelifts done and how have they been done in the past? So if you were around in the 50s and the 60s and you were contemplating getting a facelift, and they were doing facelifts then, how would it be done? We had a very basic understanding of the anatomy of the face at that time. What would happen is that here's the ear. You would make an incision in front of the ear, just like this, okay? And it goes behind, but well, let's not complicate that too much. And then you would lift the skin up off the deeper layer, like this, okay? It'd be almost like skinning a chicken, okay? As you are dissecting under the skin, you would encounter these anchor points. And understand about these anchor points, they go very deep. They go all the way from the bony structures, through the SMAS, through everything in the face, up to the underside of the skin. So you're going under the skin like this, and you would encounter these fibrous anchor points, and you would encounter them, and you would cut them, okay? And so I'm gonna take these out and put it in my trusty little needle cushion here. Alrighty, and you would go ahead and you would put them over there, okay, because you've taken them out, and you would dissect forward. And so you would lift the skin way forward like this, release all this. And remember, you're doing a facelift because, you know, this man or woman has some crepey skin, some excess skin. And then what you'd do is you'd re-drape the skin back, okay? And then you'd kind of pull on it like this, all right? And, you know, you could actually freshen somebody up back then and make them look a little bit better. Bruising would go away, then they'd look better, okay? Now, what's the problem with this? The problem is pretty intuitive. All of you already know. The skin is not a supporting structure. It's not a strong structure. It's a covering structure. And therefore, this patient might look better for a little while. And I mean for 6 to 12, maybe 15 months. But then what would happen? The skin would stretch, just like when somebody packs on a few extra pounds because they drink too many beers. You know, the tummy stretches, the skin of the face would also stretch. And so even though you've pulled it back like this, it would stretch back down, and all you'd be left with, 18 months later, you'd be looking pretty much the same with the droopy skin. All you'd be left with was a widened scar right here because the skin is pulling against that incision and widening it, okay? So that's how things were done in the 50s, 60s, and this period of time, and the results were very mediocre. Thank heavens, The skin-only facelift is not unheard of today, but it's very rare. Relatively few people are just doing a skin-only facelift. So I'm putting these retaining structures, these anchor points back in to get to the second part of the story. Okay, so what happened? In the late 1960s, anatomists studied the human face closely and taught us surgeons a lot about, the face that we didn't understand. So remember, you bring forward the skin like this and you got this red layer. And sort of this is when they christened it the smas in the cheek and then the platysma in the neck. And they said, well, hey, surgeons, this layer here is the real strength of the face. And so you should be paying more attention to this as you do facelifts. And so we did. We shifted. We moved away from pulling on the skin and we started to essentially find ways to pull on the smas. Now there's different ways that this is done. You might have heard of a plication facelift where you sort of scrunch this layer onto itself. You put in some sutures and you just pull back on it. There's another kind of facelift called an imbrication facelift where you actually cut a strip of this smas layer out and you suture those two cut edges together. These are various ways to pull on the smas. But here's the key challenge, the key problem with these kinds of facelifts. And these so-called smas, imbrication, or plication facelifts are the majority of facelifts done in the United States today, okay? The problem with this is, well, we got to go back to these pins. Remember the pins, these fibrous anchor points. You can pull on this red muscular layer as much as you can, but if these pins are still in place, these anchor points that go all the way through the smas and pin it down to the bone, it really doesn't work very well. And so this is where sometimes you hear complaints about facelifts. Well, geez, I did a facelift and I think I look pulled or stretched. Guess why you look pulled or stretched? Because you are pulled and stretched, because they're pulling on this and Mother Nature is pulling back because these anchor points are here and they're not giving way. And so number one, you might indeed look a little pulled, a little less than fully natural after this sort of a facelift because you are being pulled on. Another problem, just as big of a deal, is that, of course, Mother Nature is pulling back. And your sutures are here trying to suspend this smas, but it is pulling back. And Mother Nature, as you know, Mother Nature tends to win. These fibrous attachments, these anchor points, were not released. And therefore, the duration, the durability of these smas facelifts, plication, imbrication, in my view, and there are differing views in the surgical community, but I think there's an enlarging consensus that it ultimately compromises the facelift unless you remove these, okay? Okay, so now let's go to the kind of facelifts that I advocate. I do something called an extended deep plane facelift, okay? So how does that work? Well, you make an incision in through the skin in front of the ear, and then you dissect the skin a fairly modest amount. You get to about here. Now what do? You don't just pull on the smas, you cut through it like this, you dissect through it, cut through it, and you make an incision here. Then what do? You dissect under the smas, which you remember is the real strength of the face, okay? Pulling on the smas is totally unlike pulling on the skin. It's a good exercise to be in because it lasts a long time because it's the strength of the face. You dissect under the smas, and of course you encounter these anchor points. And what do? You cut through these anchor points, right? And so let's put it in my trusty pin cushion again over here. You cut through all of these anchor points, right? Boom. And then now you've got room to run. You dissect forward in this deep plane area. You keep the skin attached to this muscular layer in front of this line here where you went through the smas, but then you're able to dissect well forward. You see how I said this was the nose? So right here, where the end of this, these colored sheets of fabric are, this is your nasolabial fold. So you dissect right up close to the nasolabial fold. You've got the whole face here. Then when you reposition this, you're not so much pulling on the smas, you're repositioning it. You don't have these anchor points pulling back against you. So when you now go ahead and use your sutures and suspend your smas flap and your skin, your composite smas skin flap, you are not fighting Mother Nature. You put in those sutures. Once those sutures dissolve, or go away, or any kind of sutures you use, it's no big deal because it's not pulling against anything, and that SMAS layer has now actually healed in its new position. And in a funny kind of way, it's not a new position, it's an old position. It's where your SMAS used to be 15, 20 years ago. We simply reposition it up there, and then it heals there, and then it stays there. Okay? So the key concept I've illuminated today is that by releasing these anchor points, and therefore doing a true deep plane, extended deep plane facelift, you can get a result that is more natural appearing, that is more durable. We hope that it lasts 10, 12, 13, 14 years, and is less uncomfortable after the surgery. And so when you are in discussions with your own surgeons and they say, hey, great, we're gonna do a SMAS facelift, I'm hopeful that this video will arm you a little bit to ask a few more questions. Okay, great, you're gonna do a SMAS facelift. Does that mean you're gonna cut through the SMAS, release the ligaments that are pinning down the face, and reposition this layer forward and get me a better result? Or are you just gonna sort of yank on the SMAS, which is sort of, we'll do something. There'll be some difference for some years after the surgery, but ultimately I think the natural appearing nature of it and the duration of it will not be as good. And so I'll finish with a little analogy. When I was training to be a head and neck surgeon, before I did a facial plastics fellowship, I did a lot of head and neck cancer work. And I can remember one of my most wonderful mentors here in my residency program used to tell us that we'd be taking some tumor out of somebody's neck or something, and he always used to admonish us, we need to spend the extra time in the OR to make sure we get all the tumor out, because if you take out 95%, even 98% of the tumor, all you've really done is done a big biopsy, because sadly that tumor is coming back and is going to compromise the patient. I know this is not cancer surgery, but I think that there is a bit of a distant analogy here. For the last 10, 15 years, surgeons like myself who spent a lot of time thinking and working on facelift surgery have been dissecting through this SMAS and inching forward and becoming more and more facile and educated about how to approach these ligaments and how to cut through them, take them down, these fibrous anchor points. The same thing as the tumor surgery. If you go ahead and lift up the SMAS and you just sort of take down these fibrous anchor points a little bit or not fully, ultimately you very significantly compromise the result of your facelift. It's incredibly important to do a really thorough, comprehensive job at releasing these anchor points, and then you can execute a true extended deep plane facelift and get your patient that best result. So anyway, I hope that was very helpful. I hope it wasn't too complicated, and I really appreciate your time in listening to this. Thank you so much.